Hello, everyone. I'm Dr. Marisa Weiss. Thank you all for joining us today. You know that managing breast cancer treatment can be a long, complex process with unexpected challenges along the way. After breast reconstruction, the hope is that you can focus on healing and getting back to life, but your regular life, but a cosmetic or medical issue with reconstruction can really keep you from feeling fully recovered, both physically and mentally. Today, we're going to talk about options for people who are unhappy or dissatisfied with a reconstructed breast, or even after you've had part of your breast removed. We're going to call that lumpectomy, or for people who have pain or discomfort that needs to be remedied. These issues can develop either after lumpectomy, with or without radiation, or after mastectomy. And please remember that you're not alone if you're feeling frustrated, angry, discouraged, and a lot of other emotions that can go hand in hand with these types of issues. A corrective surgery may be able to help you, and I hope that what you learned today will empower you in your search for feeling better and feeling more like yourself and looking more like you want to be looking. First, I'd like to thank our generous sponsor, the Center for Restorative Breast Surgery. They are a long-standing supporter of Breastcancer.org. Thank you so much for making this program possible. We have a phenomenal panel here with us today of our speakers. Dr. Ann Peled is co-director of the Breast Cancer Center of Excellence at Sutter Health, California Pacific Medical Center in San Francisco. Dr. Peled is a board-certified plastic surgeon with a background in both surgical oncology and reconstructive surgery. Dr. Diva Srinivasa is founder of the Institute for Advanced Breast Reconstruction in Thousand Oaks, California. She is double board certified in both general surgery and breast plastic surgery and completed a fellowship in microsurgery. Dr. Sarosh Safar is a double boarded certified microsurgeon in plastics and reconstructive surgery and general surgery at the Center for Restorative Breast Surgery and the St. Charles Surgical Hospital in New Orleans. Thank you all so much for being here and for doing what you're doing. You are a rare group of people with excellence in this really important area. I'm looking forward to getting your insights in just a few moments. As always, we look to you, our breast cancer community, for what matters most. We'll be including many of your questions in the discussion today, including answers about who can have corrective breast surgery and when, the risks and benefits, options for creating symmetry, what to do when major issues occur after getting implants or having a flap reconstruction, which is when you use your own tissue to rebuild a breast, revision surgery on radiated skin or after an infection happened, finding the right surgeon, and how to pay for a revision surgery. We'll get into all these topics and more in a few minutes. In preparing for today's webinar, we wanted to know about your satisfaction with the results of your reconstructed breast after a mastectomy or lumpectomy. And here's what you told us. 85% of you said, no, I don't really like how my breast reconstruction, the way they look or the way they feel. And 15% said, yes, I'm happy with the results. Now, these answers came from nearly 800 of you who signed up to join us today. And while it might not be surprising that so many people are dissatisfied, given the topic we're here to discuss, it really underscores the importance of ensuring that you know your options so that you can feel more confident, comfortable, knowledgeable, and happy with your reconstructed breast or your altered breast after you've had partial breast tissue removal. And it's now my pleasure to welcome Dr. Peled, Dr. Srinivasa, and Dr. Safar. I'm going to start with Dr. Srinivasa. A lot of people have asked how they know if their recovery time and pain level are normal after reconstruction following a lumpectomy or mastectomy. Typically, what should people expect?
I think in general, and again, this is in general because recovery is such a personal process. In general, what I say is with the lumpectomy, the first 3 to 5 days, you're going to feel that incisional pain, that sharp pain, throbbing. That achy throbbing will usually continue on for 7 to 14 days. By 2 weeks, I find that most patients should be off of narcotics, on non-narcotic pain medicine. By 6 weeks, I expect that most patients are fully healed. And I think if at that point you're still feeling pain, it's important to talk to your doctor about it and help describe that pain, because we have different medications that target different kinds of pain. You had mentioned nerve pain. And like you said, when the nerves are cut from surgery, they're going to wake up and they're going to want to grow back. And that can be treated with very specific medications that are different from maybe a dull, aching, throbbing pain. For a mastectomy, in general, the pain does last a bit longer. I find that that sharp incisional pain can last up to 2 weeks. For another 2 to 3 weeks, I think most patients will experience that aching, throbbing type pain. Again, by about 6 weeks, I expect that most of that pain is gone. And if you're still in significant pain, you should talk to your doctor about it, describe the pain the best you can, and keep track of what you're doing to help with the pain and what medications you're taking so they can help guide you for the best options.
Yes, and it's after the nerves have been cut and they're ready to regrow, and of course you want them to regrow, they can have an attitude and kind of hold a grudge, and you might feel like flickers or zingers or crawly, itchy, weird feelings, both in the area of the breast. And if you've had a lymph node dissection in the armpit, it can actually go down the arm to the elbow, sometimes in the back here. It really depends on the extent of surgery. And if you've had chemotherapy that kind of decreases the ability of the nerves to heal, like Taxol or Taxotere, that can delay the time. It can push off the time that the nerves are healing, and you might feel later on more discomfort than you had earlier on, and that might come as a surprise. Dr. Safar, who is a good candidate for a revision after reconstruction? Are there factors that make a revision surgery riskier or less likely to be successful?
Well, thank you so much for having me, Dr. Weiss. And before I answer your question, I just want to mention how startling your statistic was, that 85% of women are unhappy with their reconstruction. That's like so upsetting as a breast reconstruction surgeon. And hopefully we can help people figure out how to get connected, who's a candidate, what are the right things to kind of ask your surgeons, and all the questions that I'm sure you have lined up for today. But just in terms of who's a good candidate, if you were healthy enough to have breast reconstruction surgery, you are probably, I would say, 95% plus chance that you're a good candidate for a revision of your reconstruction. I think one of the biggest roadblocks that patients have is the fear of opening their bodies up again to surgery. If they're unhappy with how their reconstruction went, that fear of, oh my God, am I going to feel even worse? Am I going to look even worse if I go and have surgery again? But most patients who've had reconstruction are going to be candidates for a revision of their reconstruction as well. Are there any things that will make your revision more or less risky or more or less successful? I would say that the one thing that can make revision surgery a little bit more difficult is probably radiation. And that depends on your radiation. And if you're out there, you know that your radiation might have been different from your friend's radiation, which could have been different from your cousin's radiation. So it does affect different patients differently. There's different types of radiation that can affect tissues differently. But I'd say that radiation or other severe complications like infection, implant-related infections, where you lose your implant, you lose all of that skin elasticity, you lose your skin envelope. Those are a couple examples. But in general, most women are going to be candidates for a revision if they've had reconstruction.
Yeah, yeah. And I'm a breast radiation oncologist, and I know that the plastic surgeons and us, radiation causes issues for breast reconstruction on a regular basis. I know that. But it's also true that radiation is a very effective method of treatment, especially for people who are at high risk for a problem after they've had mastectomy. So people, for example, who had inflammatory breast cancer, that's when breast cancer enlarges the breast, usually it affects the breast diffusely and involves the skin. The skin can get pink, red, and extra swollen. That the radiation is really key to reduce the high risk that it could be a problem again in the future. And so the dose that radiation is given to the skin is higher, making it more tricky to have reconstruction later. But you guys are amazingly, well trained to deal with those types of complications. And when you bring the fresh, and when you bring the fresh tissue in with fresh blood supply, then you can sort of help that area heal and regain some of the health that you may have lost, or some of this. It may revitalize the area by bringing in fresh tissue.
Absolutely.
Yeah. Dr. Pellet, I was going to ask you, a priority for many people is having breast symmetry, so that you look even after lumpectomy or mastectomy. And I know that's tricky because some people might have natural asymmetry, lopsidedness ahead of time, but when they're finished with all this, they want a nice set that looks good together. What are options for creating a more symmetrical appearance with one or both reconstructed breasts?
So I think, one of the things we know is a lot of this really depends on what you're looking at for your cancer treatment. So I say this with love, Dr. Weiss, as you know, my mom and sister are both breast radiation oncologists, and we always say, like, we can work with what we have with the effects of radiation if it means we're decreasing the chance of a local recurrence. But with radiation, we do know that things change over time. And so I think sometimes, especially if we're talking about lumpectomy, where we're taking part of the breast, we know that if you do need radiation in that setting, the changes that may happen can take a year or sometimes even 2 years before we really have a sense of what that's going to look like. So sometimes women who may have larger breasts that kind of are less dense, they may actually have a lot of volume change. They may have breasts that get higher and tighter. And so it can be hard sometimes to predict what the asymmetry is going to be. So what I would say to people is, first off, know that we do have lots of options for symmetry. So for instance, in that setting, one of my favorite things to do is to try to do a lift or a little reduction on the other breast. So we're not going back for some of the radiation challenges that Dr. Zafar brought up, but we're able to just make the other side match. So we achieve symmetry, but we're kind of decreasing the risk of going back in radiated tissue. And then if we're thinking in the mastectomy setting, often, even if people don't want to have a mastectomy on the other breast, which is very reasonable in many settings, we have options, whether it's adding a small implant if we need to adjust volume, whether it's doing a lift, adding fat grafting for volume. So again, I think a lot of it is really figuring out how long are the treatment effects going to take for us to really go in. So when we do surgery, we're doing the very best thing at that time and allowing those changes to settle out.
Right, right. I liken breast reconstruction to renovating a kitchen, in the sense that, you had your breast before all this happened and you were fine. You knew wherever, you knew what you had and they were okay. They got older looking as you grew older, and they were just there. You know what your breasts look like. As soon as you go for reconstruction, just like as soon as you get a new kitchen, all of a sudden every detail matters. Like the depth of the cabinets, the distance from the stove to the refrigerator to the sink, the pulls, the way the door opens and closes, the layout, the counter, everything. And it's amazing when I think part of the challenges of breast reconstruction is that you initially are so fearful because you've been diagnosed with breast cancer and you meet the breast cancer surgeon, and then peripherally you then meet the plastic surgeon, and you don't really understand that you're actually going to have a longer relationship with that breast plastic surgeon, that you'll be seeing them more frequently than your breast surgeon. And so it's a lot of it is, patient education to really help people understand what to expect when they go through all these steps, so that they know what your role is in their care and how incremental it is. Like, you can't do it all in one fell swoop. The goal is to get you to a better place, but it can take a number of careful steps to tweak you to get to the right place so that you're happy at the end. Dr. Pella, just a follow-up to the question that we received about symmetries, is this expression about uniboob. People say they don't want like one, a uniboob. Can you describe what that means and suggestions for fixing that?
Yeah, basically when people talk about uniboob, what they mean is that the central part of the breast part around your breastbone that is naturally a divider between your two breasts essentially gets opened up. And oftentimes this can be related to the way the mastectomy might be done. It can also be related to kind of the way your tissues evolve over time. But if this does happen, fortunately, we're able to fix it, whether it's making a choice to reinforce the pocket. So sometimes using a mesh and kind of essentially recreating that space and closing that down can be really helpful. And then other times there are questions around, should we put in a smaller kind of reconstruction to kind of take some of that pressure off of that area and allow for more space? But I would say, fortunately, it's something we see less and less. As my breast oncology surgeon hat, I've been really happy to see how thoughtful many breast surgeons are really taking on this idea of doing better and more thoughtful mastectomies around preserving blood supply and nerve supply in the breast borders. And so I think we're seeing less and less of that, fortunately, and are better at correcting it.
Great. Well, certainly you guys are leading by example, and we are so grateful for that. Dr. Srinivasa, several people in our audience are asking, when do implants need to be replaced? Because they may have read somewhere that they expired a certain time. And one person asked whether there's an option to go flat instead of getting replacement implants.
Yeah. So for the first part of the question, generally the most common thing I hear from patients would be, do I need to get them replaced every 10 years? I think that's the most common statistic that's out there. And I think that 10-year marker came from two things. One, the most common implant warranties last about 10 years. And the other thing would be, in general, statistically, women are likely to need something about every 10 years. So if your implants have no issues, they're soft, they're not bothering you, there's no reason to have surgery to replace them just because it has been 10 years. That said, if you're having really tight scar tissue around the implant, there's malposition, it's ruptured, those would be reasons to meet with a surgeon to talk about replacing them or going flat. Having a flat aesthetic closure is always an option at any point in your reconstructive journey, including after removal of breast implants for reconstruction.
Thank you. How many people come back and say, I like my implants, they're okay, but I actually want to be bigger. And so rather than going flat, they want to have an enhancement of what they have.
I find that it happens often that women want to go bigger, but when I try to discern what it is that they specifically dislike about their breast reconstruction, it's not necessarily that they want the implants to be bigger, but it may be that, especially with under the muscle implants and as they age, the implants have moved. They don't look like they did when they were first placed. They may have dropped or bottomed out. They may have fallen down and out. And so what women are missing are the natural cleavage and upper pole fullness that's most often visible with clothing and in bathing suits, for example. So if that's the case, it may not necessarily be that you need bigger implants, but rather repositioning of the implants, possibly going to above the muscle, like Dr. Plaid said, placing a mesh to sort of recreate the pocket to enforce those implants to sit closer together and give you natural cleavage. So it does come up often, but I think it warrants further discussion to know what exactly is bothering the patient so we can fix it the right way. And the answer may not necessarily be simply upsizing the implant.
Okay, thank you. Thank you. Dr. Safar, can you explain what capsular contracture means and the options you have to fix it? And then how to, after you fix it, are there steps or things you can do to keep it from happening again?
Sure. Capsular contracture is basically scar tissue that forms around your implant. And I like to think of it as kind of a shield that your body makes around the implant to separate it from the rest of your body, kind of protect your body from something that is foreign. And for the women out there who had to have ports placed for chemotherapy, your body also creates a capsule around a port, just like if you had an artificial knee or a hip. Specific to breast implants, when that capsule or that scar tissue starts to become thick or tight, it can start to change the shape of your implant. It can move the implant so that sometimes it sits higher or sits off to the side. It can sometimes, what's very, very difficult to handle is shift your nipple position. And sometimes in the worst cases, it can create pain and discomfort. Some of the things that we do to make it better are if you still want to go the route of implant reconstruction, removing the implant, removing most or all of the capsule, placing a fresh implant, potentially adding dermal matrix. In patients who've had radiation, it's probably a little bit more challenging to overcome capsular contracture just because of the nature of radiated tissue. But ultimately, if you keep having problems with capsular contracture and we can't get a hold of it, ultimately, especially we're a little bit biased at our center because many women come to us to have their implants removed and have that replaced with their own tissue. But ultimately, replacing that implant with your own tissue can overcome capsular contraction.
Interesting, thank you. Dr. Pellet, we received a question asking if corrective surgery can return sensation to the nipple and the breast, to give you back your playground. What's possible with that?
Yeah, so I would say, in our practice, we do a lot of primary nerve-sparing, nerve reconstructing mastectomies. And ideally, if you're someone that's kind of in that decision process, or you've had a lumpectomy and are maybe thinking mastectomy, the best time to keep sensation is at the time of mastectomy. But if that hasn't happened, what we find is we can actually go back and look for nerves to reconstruct. So for decades now, people have been going back and using flap reconstruction, and you can take a nerve with the flap. You can also look for a nerve in the chest, and you can actually do a nerve reconstruction during the same time as the flap. And lots of studies have actually shown that increases return of sensation, and people can, especially if you're bringing up a big piece of skin with the flap, like in a delayed setting, you actually can get great sensation back to the skin. It's been more recently, though, that people are actually thinking about doing it with implants. And the reason for that is because unlike with a flap where you can bring a nerve with you, when you're going back in a setting of an implant, you don't know what the nerve is going to be like till you get there. So we do a lot of these in our practice. And unfortunately, I don't know till I get in there, is there going to be a great nerve to find to reconstruct? Is it going to be scarred in? Is it going to be way back in the chest where I can't get it? But what I always say to people is if you're thinking about a revision, ask your surgeon if they'll be willing to look for nerves and try to reconstruct them, because there's no harm in looking. And if we are able to find a nerve, we're happy to do a nerve reconstruction with nerve grafts and really try to give people back skin or nipple sensation. So I would say it's definitely possible, but sometimes we don't always know how likely it's going to be successful until we get in there.
Right. And it's not just sensation. You want an erogenous, you want it to feel good, a good sensation. And that's the goal, of course, is to try to help people recover that if possible.
Yeah, I think that's the dream, right? That's what we all would hope is our highest bar. But I think, to be honest, I always think about one of my friends who had mastectomies before we started doing these sensation sparing ones. And she said she puts on a sports bra and doesn't know it's on. So I think, unfortunately, with traditional mastectomy, a lot of people will literally tell you it's like they had lidocaine to their entire chest. And so I think what I would say is, like, we strive for what you mentioned, but even if you're someone that misses like what it feels like when you feel warm water in the shower on your chest, or you feel what it's like to have a family member hug you, like, it's possible to get back to that, even if we can't quite get back to that ultimate goal of erogenous sensation. So I guess I sort of would hold that hope for people of asking, even if it gets better, most people are still so grateful for something.
Yes, absolutely. Thank you. Dr. Srinivasa, how often do you hear people sort of report that they're not happy with the way that the donor tissue site has healed? Like, wherever you borrowed the tissue from, that is what I mean by the donor tissue site after flap reconstruction. How often is that an issue, and what can be done to help with scarring or preventing things like hernias or other things at the tissue donor site?
Sure. So anytime we're doing flap reconstruction where we're taking skin and fat and hopefully in a muscle preserving fashion and moving it for a breast reconstruction, we call that autologous reconstruction. Auto meaning your own, logos meaning tissue. The goal being we can reconstruct the breast without an implant, but it means we're taking it from somewhere. And we refer to that as the donor site. So donor site complications, honestly, the data is all over the place. My general recommendations are to ask your plastic surgeon for before and after photos that mimic your starting point so you can have an accurate understanding and calibrate your expectations for what it's going to look like. So how high is the scar placement? You had mentioned hernias. Hernias are far more common when the DIEP or deep flap, which is taken from the abdomen, is perhaps not done as a true DIEP flap and more like another acronym we use called a tram flap. And the difference between these acronyms is the utilization of muscle along with the flap. When you move the muscle from the abdomen, you're at higher risk for a bulge. It can also happen with deep flaps, but it's much, much less common. So I would say it really depends on your microsurgeon. How do they do the operation? You just have to ask them, say, hey, do you see this? How often do you see it? And how do you fix it? Bulges or hernias can generally be fixed with tightening the abdominal wall or placement of a mesh in some cases. Scar placement, sometimes the scar can be lowered at a revision, sometimes not. I personally really like to use lipocontouring and liposuction techniques to help contour the abdomen and also utilize that fat for fat grafting. I think in general, discussing a revision is just really important. Every surgeon has their own philosophy or ethos on how they approach this. For me personally, in my practice, I tell patients, hey, we got a lot to get done at the time of your mastectomy, especially if we're connecting nerves and we're sparing skin and nipple and all of that. You know, my goal is to thoughtfully transfer the tissue and do a good job to try and make the tummy look as much like a tummy tuck as possible, but it's not the exact same thing as a tummy tuck. However, there's this operation called the revision that we can do as an outpatient, a minimum of 3 months out from surgery, longer if you'd like. And that's really the opportunity to fix issues at the donor site. So it's a long-winded answer, but I think I would say in general, the most important thing is know that revisions are an option. Talk to your surgeon about revisions and sort of their general philosophy on it and what can be done even from the beginning if possible. And try and get a good understanding of before and after photos, what you can expect, and whether your surgeon is someone who does the operation in a truly muscle sparing fashion.
Yes. What about for people who are now who are overweight before this whole thing started, and now they're on these new medicines and they've had bariatric procedures, they've had serious, significant amount of weight loss. And now things are kind of hanging in a way that they weren't up front. Is that a reason for revision?
Absolutely. It still can cause issues at the donor site. So we can definitely go back and excise additional skin. Plication is the term that we use for tightening the abdominal wall or bringing muscles back together. So repeating that plication is always an option. And usually things don't just change in one spot. So if you've had fluctuations in your weight, you may also notice it in your breasts. So that may be an opportunity to not only address the donor site, but you can utilize the fat that you take from the liposuction to help contour the donor site to then re-inject as fat grafting back into the breast as well.
Okay, thank you. Thank you. Dr. Safar, someone asked if switching their implant from under the muscle to over the muscle is now sort of the right thing to do, something they should check out. And can you talk about sort of what goes into this decision? What is your insights there?
I think Divya touched on this a little bit earlier, and I really liked kind of how she described that it just depends on what the problem is that you have with your implant. And so it ends up being really a conversation with your surgeon, and you just openly, honestly telling your surgeon, hey, this is what I like about my implant. This is what I don't like about it. Specifically, I think this question might be related to some patients who, when their implant is behind their muscle, every time they activate their pec muscle, which is something we activate all the time throughout the day, especially when we're exercising, it can kind of squeeze the implant, push the implant down and out. And that's something that we call animation or hyperanimation deformity, which is just a big word for saying the muscle pushes the implant and just looks strange, unnatural, and odd. For some women, switching the implant to sitting on top of the muscle can be an option. You just have to know that if you have a very thin mastectomy flap and you don't have much tissue behind your skin that was left over, sometimes it can make where the implant meets your chest wall look very obvious, like an obvious switch from implant to your chest wall. One other option that some patients may kind of consider if they talk to their surgeon is going in and dividing the little nerve that goes to your pectoralis major muscle, and that's called a pec nerve neurolysis. And sometimes that can soften the function of your muscle and stop some of that hyperanimation deformity and can kind of soften or blur that line. And so there are a few different options that go into it. But do I think everyone who has their implant behind their muscle should shift it to above their muscle? Absolutely not. It's really a conversation with your surgeon and a physical exam, and your surgeon looking at what happens when you activate your pec muscle.
Right. And, just the comment about trying to leave the muscles alone and try to use, skin and fat to recreate the breast is an important consideration because, every time you
Absolutely.
modify the muscle, that muscle might not work as well in the location where it lives, like your sit-ups in your belly area, or if you're using the muscle back under sort of right behind your armpit area here. I know a pediatrician who had reconstruction who couldn't flip the babies as much because she couldn't twist in the same way. Likewise, if you do remove an implant from under the muscle and the pectoralis major muscle, the one right underneath the breast area, and that muscle's now had been stretched out to accommodate that implant, will that muscle get back to work and will ever get its tone back so it can do its job again in a right way, or does it kind of stay stretched out and kind of like, semi-retired mode kind of thing?
Depends on the situation, but for some patients, some of us naturally as women have super thin, smaller pec muscles. Some of us as women have really nice, hardy muscles, and it probably depends on some genetic factors. Probably depends on how much your nerves have been stretched, how long you've had the implants, how long something called muscle atrophy has set in, which is where if you don't use that muscle for a long time, it will kind of lose its function. So I think, again, case by case basis. But I do find that a lot of our patients who have their implants behind their muscle, they come to see us because they hate the way it feels, looks, or functionally they have a problem with it, who get those implants removed and have the muscle put back down on their chest wall and have a flap instead. I mean, almost unanimously, the morning after surgery, they say, already I feel so much better. So, yeah.
Wow, it's amazing what we
Yeah.
adapt to. Like human beings can adapt to all kinds of circumstances, and just because you adapt doesn't mean it's a healthy thing physically or
Correct.
emotionally.
Absolutely.
And I know all of you, in your practice have discovered this, and I'm a dual citizen, both a doctor and a breast cancer survivor. And I'm fascinated every day how, in everyone's life, there's always more things going on than just their breast cancer. They've got kids with issues, they have, work issues, they have other medical problems. Like, we women lead a complicated life. And the reconstruction ends up being an opportunity for them to feel better about themselves and sort of like go back to a new normal that they can feel good about. Dr. Srinivasa, how do you manage the fat necrosis after flap reconstruction surgery? And what kind of revision may be needed? And can you sort of explain what that fat necrosis is?
Absolutely. So when we do a flap, like a deep flap, where we're transferring the fat and skin, it's based on the blood flow that we transfer with it. Either in the short term or over time, that blood flow may be insufficient to reach every last bit of fat that we transferred. So in that case, you can develop something called fat necrosis, or a death of that fat, which then becomes either it can be sort of oily and bubbly, it could be liquidy, like a thick white liquid, or it can form a hard knot or a hard ball. And expectedly, in a woman who's already been through a breast cancer diagnosis or has a genetic predisposition, that can be particularly stressful. So if you are concerned that you have developed fat necrosis or those hardened areas of fat after flap transfer, it can definitely be addressed. It falls on a spectrum. It could be a tiny little bit of fat necrosis. It could be a lot of fat necrosis. For smaller areas of fat necrosis, it depends on how much it bothers you. For some women, they say it doesn't bother me at all. it looks completely normal on imaging and we don't have to do anything. For some women, it's anxiety provoking that it's a lump and they can feel it, or imaging may look abnormal. So they may choose to do a biopsy, or we can excise it at a revision and then send it to pathology. If it's a large area of fat necrosis, which is uncommon but can happen after a flap, I first like to remove the entire area of fat necrosis and see what the defect is. If it is something that I can fix with fat grafting, that's a great option. Sometimes, though, it's not something I can fix with fat grafting. And in those cases, I've actually gone back in and done a smaller flap from somewhere else. If they already had the flap from the tummy, we can also take fat from the love handle area, from the inner thigh, from right below the buttock crease, and we can move those flaps to fill that defect and then recontour the breast, again, with soft, all natural tissue, but to replace the fat necrosis that occurred.
Now, when you use liposuction technique, you fill up a syringe with, let's say, fat, and you mix it up, and then you put it back into an area where there's like a concavity or an some kind of indentation, or you just want more fullness there. What's the chance it's going to sort of like stay there and get the blood supply it needs so that you don't get fat necrosis again?
That's a great question. And it depends on the home that you're injecting it into. So if you remove a large piece of fat necrosis and you have a big hole, if you were to just put fat in there, it wouldn't survive. The way fat grafting works is that the fat you inject doesn't have blood flow with it like a flap does. It is depending on the environment to grow blood vessels in and around it and form new blood supply that then supplies the fat that you injected. So it depends on the quality of area you're injecting to. You can't inject into a vacuous hole, but you can try and inject into the tissues around it to help fill it in kind of from the outside in. And if that tissue has been radiated, the fat may not take very well. If the tissue is otherwise really healthy and the flap is otherwise really healthy, then you have a good chance that most of the fat will take because you're injecting it or placing it into a healthy environment where those blood vessels will grow back.
Okay, thank you. Dr. Safar, if you're seeing a patient who who's about to have mastectomy and they're at high risk or something, you know that it's likely that they're going to need radiation at some point in their care. After their breast surgery reconstruction, maybe they had chemotherapy up front, whatever it is. How do you coordinate or work together with your radiation oncologist to sort of minimize the risk that radiation will interfere with the best result of your plastic surgery? How do you communicate, and how do you optimize the ultimate result when you know someone's going to have radiation?
You always have to start, I think, with a conversation with your radiation oncologist and understand, what type of radiation does the patient need? How much? What's the field? Is it, can I temporarily put an implant in at the time of their mastectomy? Should I go ahead and do a flap at the time of their mastectomy? What does their donor tissue look like? How much extra tissue do they have in other parts of their body that we could potentially use? And so ultimately, there are a lot of factors that go into it, but having that open communication with your radiation oncologist, just like having that open communication with medical oncology, is pretty critical in making sure that patients are getting the best care that they can. And that's why, just like in major cancer centers, the team-based approach is always kind of the best option.
Yeah.
I think it's always really nice as a patient to ask those questions to both your plastic surgeon and your radiation oncologist. And that can help you understand as a patient what you need, what's the best option, and how to make an educated decision about what's going to be the best thing for you.
Right. And generally speaking, tissue reconstruction, your own tissue reconstruction, gets along better with radiation than implant reconstruction. And sometimes, given that after radiation there might be a little shrinkage, some plastic surgeon might make that side that's going to get is going to get radiated maybe a little bit fuller, just knowing that, to anticipating that effect.
Absolutely.
Yeah. Okay, thank you. And Dr. Pellet, what advice do you have for people looking for the right plastic surgeon to do a corrective procedure? I mean, we know how highly trained you all are and how much expertise and experience you've had to gain over the years. Like, how do you find that plastic surgeon to do that special work?
So I guess I would start on, I think what you're hearing from all of us, and as you said as well, unfortunately, unlike say breast augmentation, where the results are much more predictable, these are surgeries that are to some degree less predictable based on other factors, based on other treatment that might be needed. They're procedures that often we are doing more than one surgery to get the results that we want. So I think in that setting, what I would say is even primary reconstruction can be challenging for some people. And so I would certainly start by going to someone that this is what they do. And that wonderfully you can see on, people's websites, you can see on what people do on social media. What are they talking about? How are they answering questions? And does it make it clear that they're someone that really is committed to breast reconstruction? I think the next piece of it is that revision surgery can be tricky, right? As you said, and I've had this myself also being on the breast cancer survivor piece of it. Like it feels a little bit elective sometimes, and it sometimes feels tricky to put yourself out there again, to go in and think about it. And I do think a lot of people live unhappy for many years because they're cancer free and feel like they should just be appreciating that. And I think in that context, people feel very different about what would merit a revision to them or what wouldn't. I see some patients that I personally look at their results. I'm like, oh, I wish they were better. And they're super happy and living their life in great. And conversely, people I'm so happy with, and they see things that really bother them. So I think what you need is you need to be able to see someone who listens to you, who really asks you in your life, your day-to-day, what bothers you about your reconstruction, and allows for the possibility of fixing that regardless of what they think and what they bring into it, but actually what you think and what you bring into it. One of the best ways to figure that out is talking to practices with prior patients that they'll connect you with. So having practices that have a buddy system, that have a social media presence with patients talking to each other is really helpful. And then I think the final thing is kind of going on these larger groups, chat rooms. I always say, little caveat with this, right, is that unfortunately, no surgeries are perfect. Every single one of us on here is going to have some surgeries that don't go the way that we hope. And so I think it's really important to try to stay open-minded if you do go on these forums, to know that you're going to get a range of opinions about different providers, different surgeons, different outcomes. But again, I think the ultimate thing is really going to someone that is truly committed to this and to cutting edge techniques and is constantly learning about breast reconstruction.
Absolutely. And to really listening to what people, as you were saying, really asking people what what are they satisfied with, what are they less than happy about, and what are their goals, and really to match it up with what's realistic. And, I know each one of us just realizes this every day, that each patient we take care of is so unique. And if you are in the forums and you hear from someone else, oh, I did this, I did that, it may be great for them, but it may not be great for you. I've seen people who've had, for example, the aesthetic flat closures. They heard it was a great thing to do, but their body was different from the person that they got advice from. And their body they may have a big belly, and then they go flat up top, and all they see now is their belly. So they might come forward at that point and say, you know what, I thought I was making the best decision at the time, but now I'm reconsidering. Maybe I'm in a new relationship. My mother had mastectomy without reconstruction at age 75, and she was widowed at 83 and met this great guy at 90. He was 90, she was 83, and she, he was fine with it, but she did look into her options at a later time, like, what about making something here that's sort of lovely and fun to play with. So you can, life evolves, and you can always revisit this aspect of your care. Dr. Srinivasa, what do patients need to understand about paying for corrective surgery, knowing that not all specialized surgeons accept all insurance plans, and what would Medicare or insurance cover if accepted by the surgeon, and what sort of language do you need to use, and to demonstrate what it is that you need and hopefully get it covered?
There's a lot that I could say about this. This could be a webinar unto itself. I think this is how I break it down. One, understand whether your surgeon is in network or out of network with your insurance plan. The office should readily be able to tell you that as you make the consultation appointment. The surgeon is not the only piece. You also need to think about the facility where they do surgery, and sometimes the anesthesiologist. There are 3 different pieces that you have to understand. So your surgeon can be out of network, but the facility and anesthesiologist could be in network. So once you know what each part is, then you have to understand what your insurance plan covers. Most PPO plans have an out-of-network benefits part of the plan. So you want to know what your out-of-pocket maximum is. That's the question to ask when you're talking to your insurance. That said, that still doesn't answer all the questions of how much do I owe? What are they going to charge me? Because different out-of-network practices have different billing practices. So it's important that you get connected way ahead of time, way before you're rolling into surgery, with the finance person in the office. Ask the questions of how much do I owe? And if what you owe them is higher than the out-of-pocket, out-of-network maximum, then you are likely eligible for reimbursement from your insurance back to you on the back end. And that would require you to submit some paperwork and what we call as a super bill. If you're seeing an in-network surgeon, then it's just per your plan and your deductible and your co-insurance. So it should follow the same thing it did with your original surgery, as long as the plan itself hasn't changed. So as you're navigating this, the one thing I like to tell patients is that if you are seeing an out-of-network surgeon, it's important to be able to explain to the insurance company why. Because most insurance companies that have these PPO plans with out-of-network benefits have something known as a gap exception, also known as a NAP exception with certain plans, or a letter of agreement, or a single case agreement. These are all sort of related terms. I'm going to say it again. Single case agreement, letter of agreement, gap exception, or NAP exception. And all of these words sort of mean the same thing, which is in certain situations, the insurance company will acknowledge that you need to see this out-of-network provider because they're offering you something novel or different, or something that will fix your problem that the in-network provider was unable to provide. And in that case, they will directly negotiate with your surgeon who may be who's out of network, so that you aren't paying the out-of-network fees, but that the insurance company absorbs that for you. And I recommend to all patients that are being seen by an out-of-network provider, you have a conversation early with the office about, do you guys participate with the letter of agreement, single case agreement, NAP exception, or gap exception, and then be able to say why you need to see that surgeon. Is it a flap that they do that your in-network surgeon doesn't do? Is it that one told you you are a candidate and one told you that you're not? Is it because you had complications and you have lost trust? Continuity of care is a big one. Maybe you saw them when they were in network and they've since gone out of network. So being able to understand what qualifies you for a gap exception can then help you create a strong argument for why you deserve to have that. And if you don't get the gap exception, then make sure you understand which parts of your care are out of network, what your out of network, out of pocket maximum is, and whether the office will provide you a super bill.
Wow, thank you. That's a lot of really important information. So basically, get to know up front how to prepare, for this whole conversation, which includes knowing how it's going to be covered and what the cost will be and how to manage that. And of course, the office has experience with that.
Yes.
Dr. Safar, before we wrap up, are there any risks for having corrective breast surgery that we haven't talked about already? And what more do people need to consider when talking about this with their surgeon?
I think we covered a lot today, but I think one of the biggest risks is just the fear of asking, the fear of reaching out, the fear of the unknown and what's going to happen. And I would say that reaching out to your network, getting your support, and talking to different surgeons is probably the best thing that you can do. When you meet with your plastic surgeon, one of the most critical things, in my opinion, just imagining as a patient what it would feel like, which, I'm not a breast cancer patient, but imagining that one of the most important things is going to be like, is this surgeon listening to what I'm saying? Are they processing what I'm saying? Are they understanding what I'm looking for? And feeling comfortable enough with that person where you can openly say, hey, this is what I really like. This is what I don't like. And then that surgeon's responsibility, in my opinion, is let me do what I can based on your anatomy. Let me get you the best, outcome that you can possibly achieve based on your anatomy. And I would say that if you can find that kind of happy medium, I think that's kind of the key. If you go and you meet a plastic surgeon and you don't feel that from them, I think you should go and try to meet more people. Imagine it's just like walking into a shopping mall and walking into different stores and saying like, hey, this is actually what I really like, and this is what fits me, and this is what what I feel like looks good on me. And I wouldn't be shy about that as a patient. I think all of us as plastic surgeons have had patients who came and met us and went and had surgery with someone else. And all of us know that that's part of taking good care of patients, is they have to be comfortable with you. And it's nice if you're comfortable with your patients as well.
Absolutely. Yeah, absolutely. Thank you. That's really important. I appreciate you all that empathy that you all have. Dr. Pellet, what words of encouragement can you share with everyone here today who is dealing with complications after reconstruction?
So I think the first thing that I'll say is that fortunately, technology, techniques, options just keep getting better and better. I might always tell people I feel so lucky to be a breast cancer and breast reconstruction surgeon in this day and age with everything we have. And so I think if you think about, good example, for instance, is people that when maybe they had surgery, their only option really was an implant-based reconstruction because they didn't have anyone who was trained in some of the advanced microsurgical techniques that the lovely surgeons on with me are both experienced in. And now we do have those techniques. So we can take someone that maybe wasn't thought of to be a flap candidate eventually, 10 years ago, and now eventually they are able to have a complicated and more advanced kind of breast reconstruction with a flap. So I would say techniques and technologies are better. The next thing is there's more access. So again, we have multiple people now throughout the country who are trained in more advanced techniques and able to offer more options and have more in the toolbox for complications. And then I guess the last thing is kind of to know that you're not alone. Again, I on a personal level, have had 2 revision surgeries myself. Like, it happens, things happen. This is something we all know, and you'll find many other patients who've been in this setting. And I think just knowing that it's okay to bring up, it's okay to acknowledge, it's okay to find a different surgeon. If for whatever reason your surgeon doesn't feel like the right fit, you're the only person who wakes up in your body every day, and it matters how you feel, not how we feel. So I really think making sure that you feel comfortable with that is important.
Absolutely. And there's no emergency. Like, it is important to take the time to find that right fit and to find the right moment. And it might be that you meet somebody and they say, okay, let's have a plan here. Before we move forward, we have to help you stop smoking, for example. We have to figure out where, you're in this big weight loss effort here. Let's wait for, to get closer to your goal weight before we move forward. Like, there's a lot of nuances here that you work with every day. But even having a plan in place can really make people feel a lot better. And I would also say that the community at Breastcancer.org has been extraordinary, like really helping each other through it, and also fighting for insurance coverage for these specialized procedures that insurance companies were trying to pull back from. So we want to just thank everyone in the Breastcancer.org community and the extended community who have worked so hard to advocate for yourself and for each other. So I think that's actually the last question for today. I want to thank you so much, Dr. Pellet, Dr. Srinivasa, and Dr. Zafar. You've done a great job. Before we go, I just want to quickly summarize some of the important information that was shared today. We'll also email links to you with articles and interviews to help you as you look into your options. Like, there are, you've heard today, and there are such a wide range of circumstances that can lead someone to having or considering corrective breast reconstruction. Things like, you've heard, discomfort, pain, tightness, a change in the way, the shape or the size or the way it feels, the position of the breast, maybe some lopsidedness, asymmetry that may have developed, maybe an implant ruptured, maybe there was a capsule that formed around the implant that made it tighter and uncomfortable and hard. Maybe there was fat necrosis that needed to be dealt with, and maybe maybe you had some other issue. These are just some examples, and of course, for each individual, you might have your own unique situation that represents your challenge. But if you notice symptoms that concern you, it's best to see your doctor as soon as possible and to ask if what you're experiencing is normal for the type of reconstruction that you had, and considering other risk factors that are going on in you specifically. When it comes to finding the right plastic surgeon, one of the key takeaways is to remember that corrective reconstruction is not the same as breast reconstruction. There are specialists who are, as you can see, highly trained and skilled, experienced and committed in fixing those problems that occur after reconstruction. It's a challenge that makes them, it gives them the chance to use all their skills to give you a result that we all hope is better for you. During a consultation, ask about their experience and if they can share the before and after pictures that our guests suggested. We'll email you a longer checklist of questions you might want to consider asking. We know that how stressful it can be to worry about paying for all the medical bills, including the cost of corrective reconstruction on top of everything else, along with any medical and emotional issues you might be facing already. So it's good to get ahead of it by finding out before your procedure, like your panel said, to find out exactly what is covered, what is your out-of-pocket costs, so that there can be no surprises. And if there is a cost, that there's a plan for managing that cost. You want to be sure to confirm if the plastic surgeon takes your insurance or if you will need to pay in full. Since, as our panel said, not all specialized surgeons take insurance or are in your network. But these specialized plastic surgeons are used to dealing with people who are outside their network, and they usually have a strategy in place or steps that you can take to figure it out. Talk with your health insurance provider and your plastic surgeon to get all the details, including how much travel will be needed, especially if you don't live near your surgeon. Don't worry about your surgeon's feelings. You know, you're getting corrective surgery. This is the time to really focus on what you need to become happier with and more satisfied with your results. Don't worry about the feelings of your prior plastic surgeon or team. You know, this is a fresh conversation and exploration into what you need to get the best outcome possible. You can find much more information about reconstruction on Breastcancer.org. We'll email you with related links, including a recording of today's discussion and the questions and answer section of today's presentation. We hope that all of these resources help you make the best decision for your care so you can live the best life possible. That's what we're all committed to helping you in that way. And I want to give an extra shout out to thank Dr. Peled, Dr. Srinivasa, Dr. Zafar, and to all of you for joining us, and also to thank our generous sponsor, the Center for Restorative Breast Surgery in New Orleans. Take care, everyone, and thank you so much.